Welcome. In this session, we'll be discussing about the clinical evaluation of glaucoma patient, including history taking and slit lamp examination. Gonioscopy and optic nerve evaluation will take up in the next session, and we have already discussed the techniques of intraocular pressure measurement in the previous session. We'll be discussing perimetry and imaging techniques in glaucoma in later sessions. Determining the race of the patient is important because primary open-angle glaucoma is more common in Africans and Latin Americans. Primary angle closure glaucoma is more common in Asians, particularly East Asians including Indians, and pseudoexfoliation syndrome is more common in Scandinavians. Most common types of glaucoma are asymptomatic until tunnel vision or loss of central vision occurs very late in the disease process. Acute angle closure attack presents with severe pain, blurred vision and conjunctival congestion. Intermittent angle closure patient can report episodes of headaches and colored halos around lights. Pigment dispersion syndrome patients can complain of pain, blurred vision and colored halos around lights after exercise. And we should also inquire about symptoms of intolerance to topical ocular hypotensive medications which are reported as discomfort immediately following instillation of the eye drop, or dry eye symptoms such as irritation and foreign body sensation. Inquiring about the refractive error of the patient is important because myopia is a risk factor for primary open angle glaucoma, pigment dispersion syndrome, and myopia can cause optic nerve and retinal nerve fiber layer anomalies which can confound glaucoma detection both clinically and on OCT. Hyperopia is a risk factor for primary angle closure glaucoma, and since hyperopic patients have a small optic nerve, a relatively small optic cup can signify glaucoma. Patients giving history of trauma can present with hyphema, which can increase intraocular pressure immediately following the blunt ocular trauma, and glaucoma can occur several years to decades later following angle recession from a blunt ocular trauma. It is also important to inquire about previous ocular surgeries because risk of glaucoma increases with complicated cataract surgery, keratoplasty and vitreoretinal surgery. And history of a refractive surgery such as LASIK or PRK is important because the reduction in thickness of the cornea can result in underestimation of the IOP when measured with Goldmann applanation tonometer. While reviewing previous documentation, we should note the maximal recorded intraocular pressure as that can be helpful to establish target intraocular pressure, and reviewing previous documentation of optic nerve status, particularly images and visual field status, is important to establish stability or deterioration of the disease process. In glaucoma suspects, deterioration of optic nerve status can establish diagnosis even in the absence of visual field loss. And in glaucoma patients, deterioration of optic nerve and or visual field status can establish deterioration of the disease process. And in these patients, we have to inquire about compliance to therapy, and we have to also consider efficacy of current ocular hypotensive therapy, and also consider recording diurnal variation to look for peak IOPs escaping detection during office hours. Taking a systemic history is important in glaucoma patients, and in patients with asthma, COPD and bradycardia. Beta blockers as topical ocular hypotensive therapy are relatively contraindicated. Migraine and vasospasm can be associated with normal tension glaucoma, and we have to inquire about hypertension, particularly its treatment, because excessive treatment induced systemic hypotension is a risk factor for glaucoma progression. Hypothyroidism is associated with raised intraocular pressure, and thyroid orbitopathy can cause raised episcleral venous pressure leading to raised intraocular pressure. Sleep apnea can be associated with glaucoma, and we have to inquire about the quality of life in a patient with glaucoma, particularly his or her ability to drive, walk, find objects and maintain social interactions. And patients reporting deterioration in quality of life may require more aggressive therapy. And in glaucoma with very advanced visual field loss, subjective changes in quality of life or quality of vision may be the only indicator of disease progression. Aggressiveness and intensity of treatment should correspond to general health and life expectancy of the patient. In treatment history, we have to inquire whether patient has taken steroids, either topical, inhalational or systemic, because intake of steroids through any of these routes increase the risk of glaucoma. And among these routes, topical steroids is most likely to increase intraocular pressure. Glaucoma patients and those with family history of glaucoma are more likely to be steroid responders as compared to normal individuals and glaucoma suspects. We have to inquire about use of previous ocular hypotensives as regards their efficacy in controlling glaucoma progression and regarding the patient's ability to tolerate these drugs, because many of these drugs can have reactions and allergies which make it difficult for the patient to adhere to the treatment regimen. Use of systemic beta blockers can reduce efficacy of topical beta blockers, and certain drugs, particularly topiramate, can cause ciliary body effusion and bilateral angle closure. Acetazolamide, which is used as an ocular hypotensive agent, may itself cause ciliary body effusion and bilateral angle closure. Drugs with anticholinergic effects such as antihistamines, antispasmodics and certain antipsychotics can induce angle closure in an individual with narrow angles. Allergy to sulfonamide antibiotics should be inquired about, and 10% of patients with allergy to sulfonamide antibiotics show cross-reactivity with carbonic anhydrase inhibitors. And we should also attempt to find out patients' adherence to previous ocular hypotensive treatment recommendations. In glaucoma patients and in glaucoma suspects, we need to inquire about relatives diagnosed with glaucoma and attempt to find their age at diagnosis, symptoms at presentation, progression of visual field loss, and current or final visual status. Examination of a patient with glaucoma or glaucoma suspicion starts with vision and refractive correction. And we must note that until very late in the disease process, central visual acuity is preserved in glaucoma, and central visual acuity does not indicate severity or deterioration of the disease process. On the other hand, in very late stages of the disease process, with loss of entire peripheral visual field, continued deterioration of central visual acuity may be the only way to detect further deterioration of the disease process. Refractive correction is a prerequisite for accurate perimetry, and we have already noted the association of various types of glaucoma with specific types of refractive errors. In the ocular adnexa, we may find evidence of ocular and systemic conditions which can cause secondary glaucoma, and these include plexiform neurofibroma as seen here in this photograph and pulsating proptosis in neurofibromatosis type 1. Angiofibromas as seen here in this photograph and Ashleaf spots in tuberous sclerosis, port wine stain as seen here in this photograph in Sturge-Weber syndrome, skin pigmentation as seen here in this photograph in oculodermal melanocytosis, and orangeolo papules in the skin in juvenile xanthogranulomatosis. Intermittent proptosis and dilated eyelid veins can be found in orbital varices. Proptosis, ocular motility limitation, ocular bruit, and pulsating exophthalmos can be found in patients with arteriovenous fistula, an example of which is seen in this photograph. Proptosis, ocular motility limitation, and eyelid retraction in patients with thyroid ophthalmopathy, an example of which is seen here in this photograph. In the ocular adnexa, we may also find side effects of treatment, particularly of prostaglandin analogs, which may cause increased periocular pigmentation, hypertrichosis of eyelashes as seen here in this photograph. And this photograph actually shows a patient using prostaglandins for cosmetically increasing eyelashes, and orbital fat atrophy and enophthalmos, which is also known as prostaglandin associated periorbitopathy. Also, Brimonidine, apraclonidine, and pilocarpine are prone to cause allergic dermatitis, in which situation we will find thickening of the eyelid and periocular skin. RAPD may be found in significantly asymmetric glaucomatous damage, and it has been found that RAPD is clinically detectable when there is a 30% or more reduction in RNFL thickness of one eye as compared to that of the other eye. Size of the pupils can also be affected by parasympathomimetic and adrenergic drugs. In the conjunctiva, conjunctival hyperemia can be found in acute angle closure attack, in which case we typically find ciliary congestion after long-term exposure to topical hypotensive drugs and their preservatives, and also in bleb infection, an example of which is shown here in this photograph. We may find follicular conjunctivitis from allergy to topical hypotensive drugs, particularly alpha-2 adrenergic agonists, and exacerbation of dry eye and pseudopemphigoid can occur due to toxicity of topical hypotensive drugs and their preservatives. In pseudopemphigoid, there is foreshortening of the conjunctival fornices due to symblepharon formation. Before trabeculectomy, presence of subconjunctival scarring should be noted because subconjunctival scarring may influence the success of the procedure. And after trabeculectomy, status of the bleb should be checked, whether it is diffuse or cystic, elevation of the bleb, size of the bleb, vascularity of the bleb, and leakage from the bleb. In this photograph, we see a cystic bleb. Leakage from the bleb can be detected with the Siddle test, in which after application of topical anesthetic, a wetted sterile fluorescent strip is touched directly to the bleb and the bleb examined immediately with cobalt blue filter. Because of the high concentration of fluorescent applied to the bleb directly with the wetted sterile fluorescent strip, fluorescence is not observed if there is no leakage. But if there is leakage from the bleb, the escaping aqueous will dilute the fluorescence, and fluorescence of this escaping stream of aqueous will be observed. This photograph shows Siddle's test detecting leakage of aqueous from the wound after cataract surgery. In the sclera and episclera, we may find dilatation of episcleral veins in conditions causing increased episcleral venous pressure, as in carotid cavernous fistula as seen here in this photograph. But a single dilated vessel can indicate a ciliary body tumor such as melanoma and is called a sentinel vessel. Slate gray scleral pigmentation as seen here in this photograph is found in oculodermal melanocytosis, and scleritis may be associated with raised intraocular pressure. The epithelium of the cornea can show punctate erosions as seen here in this photograph due to drug toxicity, and these punctate erosions are particularly found in the inferonasal interpalpebral region of the cornea. Microcystic edema as seen here in this photograph as very small dark dots in the corneal epithelium indicate acute severe elevation of intraocular pressure. In the corneal endothelium, a large number of findings can be seen in glaucoma patients. Breaks in Decimate's membrane called Habs occur due to corneal enlargement when there is IOP elevation before 4 years of age. This photograph shows Habs which are horizontal or circumferential. In contrast, breaks in Decimate's membrane in forceps-related birth injury are vertical in nature. Rockenberg spindle can be found in the corneal endothelium of patients with pigment dispersion syndrome as seen here in this photograph. Flake-like deposits in the endothelium can be found in pseudoexfoliation syndrome, and a beaten bronze appearance of the corneal endothelium is found in patients with iridocorneal endothelial syndrome as seen here in this photograph. We can remember Habs as horizontal, as both Habs and horizontal start with H. Vesicular as seen in this photograph and band-like lesions as seen here in this photograph can be found in the endothelium of patients with posterior polymorphous dystrophy, and in patients with herpes simplex virus endotheliitis who can have trabeculitis resulting in raised intraocular pressure typically have diffuse stellate creatic precipitates all over the corneal endothelium in the affected eye. Corneal guttata in the corneal endothelium needs to be noted prior to combined cataract and glaucoma surgery, and anteriorly displaced Schwalbe's line, also called posterior embryotoxon, as seen here in this photograph, along with high peripheral anterior synechia, are found in patients with Axenfeld-Rieger syndrome. And we may find evidence of previous trauma or surgery, particularly penetrating keratoplasty, which is followed by a very high incidence of intraocular pressure elevation, which usually starts 6 months after surgery. Depth of the anterior chamber is determined by contour of the iris and the position of the crystalline lens behind the cornea. In pupillary block and in plateau iris syndrome, the central portion of the anterior chamber is deeper than the peripheral portion of the anterior chamber. But we must note that in plateau iris syndrome there is no pupillary block, and this is very important to remember. In malignant and other posterior pushing forms of glaucoma, the crystalline lens along with the iris is pushed forwards towards the cornea, as a result of which the central and the peripheral portions of the anterior chamber are equally shallow. And in pigment dispersion syndrome, anterior chamber is very deep and the anterior surface of the iris is concave. Width of the anterior chamber angle can be estimated by the Van Herik method, which assesses the limbal anterior chamber depth, as shown here in this photograph. In this technique, a thin slit beam is projected from an angle of 60 degrees just anterior to the limbus, and an LACD of 25% or less of the corneal thickness indicates a shallow peripheral anterior chamber. In a patient with unilateral angle closure attack, corneal edema in the affected eye may preclude angle assessment, and angle assessment of the contralateral eye can be useful to arrive at the diagnosis. But Van Herik's method is not a substitute for gonioscopy, which is the gold standard for evaluating angle status. And it has been found that compared to gonioscopy, LACD has a sensitivity of 94% and specificity of 87% in determining the angle status. Contents of the anterior chamber should be evaluated before dilating the pupil, and these may be red blood cells as seen in this photograph, white blood cells and flare as seen here in this photograph, or pigments. The iris must be examined before pupillary dilatation, and as we have discussed, contour of the iris helps us in distinguishing between the various types of glaucoma. Patency of iridotomies, if present, are noted, and deposits along pupillary margin can be found in patients with pseudoexfoliation syndrome, as seen here in this clinical photograph. In the iris, we may also find evidence of trauma, such as sphincter tears, which are very small discontinuities in the pupillary sphincter, iridodialysis, which is detachment of the iris root from the ciliary body, as seen here in this photograph, and iridodonesis, which is instability or fluttering movement of the iris due to inadequate support from the crystalline lens. Posterior synechia, as seen in this photograph, is an adhesion between the pupillary margin to the anterior surface of the crystalline lens. Posterior synechia typically occurs following anterior uveitis and prevents proper dilatation of the pupil. Peripheral anterior synechia, as seen here in these two photographs of the same eye, is an adhesion between the peripheral iris and the peripheral cornea, leading to closure of the anterior chamber angle. In these two photographs, there is a very broad peripheral anterior synechia involving the superior portion of the iris. Neovascularization of the iris, which initially appears as a fine tuft of vessel either in the pupillary margin as seen here in this photograph or near the iris root. Early neovascularization of iris requires high magnification to identify, but later well-developed neovascularization can be very prominent. And it has been seen that 90% of patients with anterior segment neovascularization, iris neovascularization precedes angle neovascularization. Ectropion uvei is the migration of the posterior pigment epithelium of the iris around the pupillary margin and onto the anterior surface of the iris, as seen here in this photograph. Ectropion UV typically occurs in neovascularization of iris. Transillumination defects of the iris can be detected, and they are said to be mid-peripheral in pigment dispersion syndrome as seen in this photograph, or peripupillary in pseudoexfoliation syndrome. Transillumination defects are readily detected in light-colored iris of Caucasian eyes, but are less frequently found in heavily pigment iris of Asian eyes. Iris atrophy can be found in eye syndrome, Axenfeld-Rieger syndrome, post-acute angle closure attack, and following herpes zoster ophthalmicus. This photograph shows iris atrophy following H0. Correctopia is displacement of the pupil from its normal site, and this can be found in eye syndrome as seen here in this photograph, or in Axenfeld-Rieger syndrome. In heterochromia, there is a difference in the color of the iris either between the two eyes as seen here in this photograph, or within the same eye. Congenital heterochromia can be seen in congenital Horner syndrome, oculodermal melanocytosis, Sturge-Weber syndrome, and Waardenburg syndrome. Acquired heterochromia can be seen in acquired Horner syndrome, Fuchs heterochromic cyclitis, siderosis, and iris tumors. Acquired iatrogenic heterochromia can occur following prostaglandin analog therapy for glaucoma, which causes irreversible darkening, particularly of two-toned iris. In two-toned iris, the iris is differently colored in the center and in the periphery. Nevus nodules and tumors can also be found in iris. The crystalline lens should be examined before and after dilatation. Opacification of the lens, such as posterior subcapsular opacification, is associated with prolonged steroid exposure, and opacification of the lens may influence perimetric results and visualization and imaging of the optic nerve head and the retinal nerve fiber layer. Instability of the crystalline lens can occur in pseudoexfoliation syndrome and following blunt trauma, and in lens-induced glaucoma, the crystalline lens directly contributes towards raised intraocular pressure, and we will be discussing the various forms of lens-induced glaucoma in a subsequent session. Deposits of pseudoexfoliation syndrome can be found over the anterior capsular surface as seen here in this photograph, and glaucoma flecken are white subcapsular lens opacities as seen here in this photograph following an attack of acute angle closure. Vossi's ring as seen here in this photograph are annular pigmented imprint of the iris on the anterior capsular surface following blunt trauma. Shy stripe, previously known as Zentmeyer's line, are pigmented lines on the posterior surface of the capsule as seen here in this photograph near the equator of the lens in pigment dispersion syndrome. And in siderosis, due to an iron intraocular foreign body, we may find yellowish brown discoloration of the lens epithelium as seen here in this photograph. An intraocular lens can cause iris chafing, particularly when a posterior chambered implant has been mistakenly placed in ciliary sulcus as seen here in this photograph, in which the superior portion of the optic is in the ciliary sulcus of the eye. Following anterior segment examination, the intraocular pressure should be measured, which we have discussed in the previous session, and following intraocular pressure measurement, gonioscopy should be done. Following gonioscopy, the pupil should be dilated for fundus examination. We will be discussing about gonioscopy and fundus examination in the next session. To recap, relevant points to obtain while taking history in a patient with glaucoma or suspected of having glaucoma are race, symptoms such as symptoms of angle closure in patients with narrow angles, history of refractive error, history of surgery such as LASIK, PRK and keratoplasty, history of ocular trauma, history of systemic conditions such as asthma, COPD, migraine, vasospasm, thyroid disorder and sleep apnea, medical history of exposure to steroids, systemic antihypertensives, topical hypotensives, topiramate, anticholinergics and allergy to sulfonamides, and taking a family history of glaucoma is very important. Refractive correction is an important prerequisite for perimetry. Ocular adnexa can reveal signs of neurofibromatosis, tuberous sclerosis, melanocytosis, Sturge-Weber syndrome, thyroid ophthalmopathy, orbital varices, cavernous sinus thrombosis, and hypertrichosis or pigmentation following prostaglandin therapy. Ocular surface examination can reveal hyperemia, follicular conjunctivitis, and pseudopemphigoid from drug therapy, status of bleb following filtering surgery for glaucoma, dilatation of episcleral veins, and episcleral pigmentation. Corneal epithelial examination can reveal microcystic edema or punctate erosions of drug toxicity. Corneal endothelial examination can show signs of Descemet's breaks, pigment dispersion syndrome, endotheliitis, posterior polymorphous dystrophy, iridocorneal endothelial syndrome, Axenfeld-Rieger syndrome, and Fuchs endothelial dystrophy. Assessing depth of anterior chamber and contour of iris can indicate the type of glaucoma. Van Herrick method is useful to assess the angle width but is not a substitute for gonioscopy. Iris examination can reveal iridotomies, evidence of trauma, pseudoexfoliation material around the pupillary margin, neovascularization, iris atrophy, correctopia, transillumination defects of the iris heterochromia, and iris chafing from malpositioned intraocular lenses. Lens examination can show signs of opacification, pseudoexfoliation, pigment dispersion, lens-induced glaucomas, glaucom flecken, trauma, and siderosis. Thank you for listening.